Thanks for letting me come and present. It's been a while since I've done this here. So thanks for the safe environment, I hope, to do this in. I had, when Dr. Gary Edwards was presenting his shoulder the other day, there was some differential stuff that I was thinking about that didn't get talked about a whole lot, and I wanted to change. I don't remember your age, Gary. Was it 42? Yeah, okay. So I changed the sex of this, so it's not exactly the same. So now my hope was that by changing the sex, you have a different idea of possibilities that exist in this patient. So nose disclosures. A 42-year-old female presents to my office with right shoulder pain. She reports that her pain started after a fall 19 years ago. I don't know if this happens to you, and when people come in like, I don't know if this is important, but I should tell you about it. And most of the time I'm like, I have no idea how that would add up, but maybe. But 19 years ago, which resolved until 3 years ago, at which point her pain returned, but without incident. She reports that she was diagnosed with bursitis and given a steroid shot, which relieved her pain for about 3 weeks before returning to baseline. She did some PT about a year ago and cannot recall if it was helpful. She has not had any other imaging. Any other questions about that? It's okay if you don't have other questions about it. This is a very typical presentation or a typical story, at least in my office. On physical exam, the physical exam is positive for anything with abduction, internal rotation, or external rotation. Like line item priority, what would your number one priority be, number two, number three?
So I think rotator cuff tendinopathy or partial thickness rotator cuff tear is not, I think would probably be my top on the differential. If she retains her strength, that's probably more likely than a full thickness rotator cuff tear. You can think about things like calcific tendinitis. In terms of the exam, shoulder stuff and neck stuff can always overlap. So I try to always at least ask in the history about, shooting pain down the arm into the hand, headaches, that type of thing for neck pathology. Those are probably kind of my top 2 or 3 things going in. And, atraumatic stuff tends to be degenerative stuff. And, kind of the tendinopathy or biceps could also be a proximal biceps tearing versus tendinopathy slap tear. The other kind of important questions to ask from the history is, if she's a 42-year-old female that played softball or threw the javelin or did overhead sports or was a swimmer for her entire career, like slap tears, like superior labrum, super common. And so having just a little bit of history about like her past sports use could give you some keys about where she's headed. So.
She liked to kayak.
Okay, that'll do it.
All of that puts you in the right direction, yeah.
You said you made some motions. Does she have full range of motion?
She can do this.
So she's got a lot of strength going on.
So she has scapular dyskinesia.
Right.
But she can comb her hair.
What's her activity like now and work?
She doesn't work. Well, she does work. She takes care of 5 children. So more work than I would ever do. And she works out occasionally, but her workouts are occasionally walking.
Yeah, specifically where the shoulder pain is?
She can't really isolate it. She says it's here somewhere and can't really get on it.
Does it wake her up at night?
It does. Yeah.
Did she have relief with the steroid shot?
She had a steroid shot.
Yeah, did she get relief with that shot?
3 weeks.
3 weeks. Oh, that's right. There it is. Right behind you.
Turns out it's a meningioma. Just joking. I want to show you me resecting a meningioma or something awesome, but instead I'll show you this. So I'll orient you here. This is a shoulder with ultrasound. So my skill is in ultrasound. I wish everybody's skill was in ultrasound so we could all get along together, but it's like I have a strange interest in ultrasound. But what we're looking at here is lateral, medial. This right here is the humeral head. This dark area is cartilage on the humeral head. This is the rotator cuff. We can't say specifically which part of the rotator cuff it is, other than it's infraspinatus and or supraspinatus, and probably a little bit of both, because we're only looking at one view, a two-dimensional view right now. We come over and we have this thing. This thing lights up. Well, lights up not a really good word. That's more like MRI, but it's hyperechoic, has a hyperechoic rim, and then it's not anechoic, but hypoechoic shadowing behind it. So there's acoustic shadowing, so which means sound's not getting through this thing as well as this thing, because we can't see it. And sound in reality is not getting through this thing at all. This is the bone, and everything behind it we just know is basically shadowing. And then it lights. Then we can see over here again. So this is what calcific tendonitis looks like on ultrasound. It doesn't have to look like this one. It can actually be ribbon-like through the tendon, but this is a nice consolidated piece of calcium. So what's not pictured here is the acromion. And so I'll put that in view in the next picture. And so I heard I could stop this maybe. Nope, I can't stop it. We'll go again. So this is the calcium right here. This is the acromion. This is abduction. So she jams this piece of calcium into the undersurface of her acromion with abduction. And so we'll see it one more time. So just, look at it one more time. I'll get the other way. Calcium, acromion, abduction. This is what I love about ultrasound, is you can do a real-time image and see what is actually, what the pathology is. So oftentimes we hear about impingement findings. This is impingement, what impingement looks like in real life. You can actually see it hitting. Oftentimes people will still have impingement without calcium, where they're jammed the greater tuberosity into the bottom side of the acromion. Also impingement. So most of the exam finding, what I was hoping to do, and hope it works, is when you check for impingement, basically what you're doing is just scouring the rotator cuff, whatever's in there, on the undersurface of the acromion. And if there's not space to clear the greater tuberosity, you'll have impingement findings. So impingement findings are just basically opening up possibilities for you for diagnosis. They're not giving you a diagnosis necessarily other than impingement. And impingement is just a garbage basket term for something's happening to pinch the rotator cuff in there and it's causing pain. But once you kind of dial it in, then you'll kind of find out what's going on. This is on X-ray, what it may look like. You have calcium hydroxyapatite formation right there in the rotator cuff. This was not her picture. This is a picture I pulled off the internet. So views. So if you want to make sure, if calcium is on your differential diagnosis, what views on X-ray should you get? Gary's going to have to answer if somebody else doesn't answer.
Just internal and external rotation views, so you make sure that you get the tuberosities in different profiles.
All right.
Otherwise, it'll just be kind of buried by the greater tuberosity on the straight ratio.
Right. So on this view, this bicipital groove coming down here, lesser tuberosity, greater tuberosity. We can see this one's associated with the greater tuberosity. But if this was a little bit internally rotated, you miss it. And so it's important to get those two views so you actually see it on X-ray. Otherwise, it's just impingement, some more impingement, and we're getting an MRI. I didn't show an MRI. Is there any radiologist in the room? I didn't get an MRI. So I guess what's the reasoning for not getting an MRI and the suspicion of, I guess, why would you or would you not get an MRI for calcific tendonitis?
If there's any tears.
So you're ruling out other pathology. So that's good. Yeah, you look for other pathology, other tears, something like that.
I guess it just depends how strong your suspicion is for cuff tearing, right? And if they've already kind of trialed the conservative measures with, like, say, I think your problem's calcific tendonitis, let's do some injections or PT and see if you get better, and if they don't, then moving on to MRI is reasonable.
Okay. Any problems with MRI and calcific tendonitis?
In what way?
It just doesn't see it very well.
Oh, you're saying for identifying.
Yeah.
That's what I was gonna say. It's so difficult to tell calcific tendonitis on MRI.
Yeah.
Like an isolated MRI, like when you compare to an X-ray, you're like, oh yeah, well then
Yeah.
that's where it is. I recognize it now, but
So the thing that's either called tendinosis or a partial thickness intersubstance tear is actually calcific tendonitis.
yeah.
Yeah.
It's super difficult to see on MRI. Like what you showed on ultrasound was way more clear than any MRI I've seen. And then usually I rely on X-ray
Yeah.
to diagnose it. Even if you just see that little kind of fleck of bone, even if it's just small, the supraspinatus, footprint, then
Yep.
that's your diagnosis.
You had another comment?
Oh, yeah, I was gonna say, there's plenty of times we see calcific tendonitis and cuff tearing,
Yes.
right?
So I got a question for you. If you take this out, what do you have?
The tear.
Right. You have a space-occupying lesion in the rotator cuff,
Great, because we love recovery.
which is a tear. And so that's an interesting thought. Yeah.
Go ahead.
To say this also just informs the clinical pathway with patients. So like, I think I should just get an MRI. I'm like, well, maybe we should start with an X-ray first, just to make sure that we know what it is. And I'll use Gary's analogy: one view is no view. Right?
That is true.
So it's why patients sometimes, because everybody hears about that from their, oh, you got to have an MRI, or you don't know what's wrong with your shoulder, or you don't know what's wrong with your back. And you're like let's go. I mean, not that, well, in the world of saving healthcare dollars, a $75 X-ray is a really nice place to start, especially with the information that you can get for it. And people are just like, I don't know, I want an MRI. I'm just like, just go. Like, you're not even going to feel this on your deductible. Like, it just gets some good information. So.
Yeah.
I was going to say, that's one of the reasons why we always try to treat calcific tendonitis non-operatively, is to go in there and shape that out. One, it's not like radio labeled. It's not like fluorescent orange when you're in there, and it's very clear where it is and where it isn't. So you're kind of exploring in the rotator cuff tendon, and it kind of looks like weird whitish toothpaste when you're shaving it out, and the tendon is also whitish, and so it's very hard to distinguish in surgery where it is and where it isn't, and you're in this like game of chicken of you don't want to take too much because then you're going to create a full thickness tear that then you have to repair, and the recovery is going to be way longer, but you also don't want to undertake it, because if you only take half of it out and then you see more flecks of bone on X-ray afterwards, the patient's frustrated with you that you went in there and didn't get it all. So this is like by far better treated non-operatively, trying to break up calcium ultrasound, needle injection, all of that is like way more effective for this.
Thank you. So calcific tendonitis, this is just some epidemiology about calcific tendonitis you can read, but the reason I stated it was a female is my hope that your mind immediately went there as a higher possibility on your differential. And as far as why female, they have some, they basically don't know. Like we have some ideas, like maybe hypothyroidism or a thyroid disorder or some sort of autoimmune disorder, maybe gallstones, like things that are more common in the female population. However, the reality is we actually don't really know why calcium ends up there. There's a few theories on why it ends up there. One could be a trauma, you get a trauma, or you have a repetitive trauma, or you just form calcium. But it happens in the supraspinatus a lot. It can happen in any tendon, but there's a high prevalence for supraspinatus. And why? Don't really know. But there also seems to be a staging of calciums. There seems to be a pre-calcific stage, a calcific stage, and then a resorption phase. We don't know the timeline of that. It could be 3 years, it could be 12 years. We don't know how fast that goes. And on imaging, we don't have a really good way to say this is in a resorptive phase or this is actually in a formation phase, because they look very, very similar. The one I showed you was just basically calcific chunk, toothpaste. If you've ever wondered, if you've never dealt with these, don't think of bone. It's not bone. It's like toothpaste or chalk. So it's very, very, very soft and almost expressible. But the difficulty is we don't know where they're at. And on imaging, the more we image, we can see different things. And that the precalcific and the resorptive phase sometimes doesn't show up on X-ray. And so you'll see it on ultrasound or on MRI as tendinosis, but it doesn't show up on X-ray very well. As far as diagnosis, this is diagnosis via imaging. Ultrasound sees it the best because we can see the formative stage and the resorptive phase. MRI does an okay job, and then X-ray would be the gold standard for diagnosing calcific tendonitis. Conservative treatment, we'll go through this quickly. Cold and heat therapy has no evidence, but it's listed on things. Manual therapies, don't know. Iontophoresis is an interesting thing. So somebody want to explain iontophoresis that does it? Yeah.
I'm gonna let David.
Okay, go.
Hey, I'm talking. It's the process of using your ions to charge, and you've got a negatively charged ion, say in
acetic acid
or dexamethasone we'll use too. That's negatively charged. You create a negative field above it with the electrode, and that drives in like repels like, so it'll drive it in through the skin that way.
Okay, so you use a little battery on a Band-Aid patch, you put acetic acid or dexamethasone on it, and you put it on there, and it drives it through the skin, through the deltoid, only onto the calcific tendonitis. So I've seen this work actually, but if I look at the studies, it works sometimes. It's like chondroitin and glucosamine. Some people it works on, and some people it doesn't, and we don't really know which group it's going to work on. And so it could be tried. NSAIDs, analgesics, haven't worked, but we tried anyway. And up to 3 subacromial injections with steroids. I didn't write that. My thought was if Gary has to go in there and do his surgery, it would be better if you did no steroids into this, because a steroid doesn't actually create resorption of calcium. It's just something we've done for a long time. And so it's one of those things like, why do you do it? Well, it's level 2B evidence. It seems to work in clinic, it's just never worked on a clinical trial. But we do it because it does decrease pain for a period of time, and 3 weeks to this lady it worked for 3 weeks. And in my mind, we just covered your pain for 3 weeks, maybe shrunk your bursa, but I don't know that it worked per se. But yeah, most of these patients report symptoms for a long time, and then they get treatment. So barbotage is one thing we try. Barbotage, I guess, is a French word. I don't speak French for bubbling. It's related to champagne, and so you can bubble out calcium out of a tendon. And so hopefully this doesn't play sound, but it is playing sound. So anyway, this is in the iliacus tendon. This is calcium deposit. This is the needle coming in. You'll see it penetrate the capsule. And this one's cool in that it just blew out the needle. It typically doesn't do that. So this was under pressure, this calcium. And then when we barbotage, we actually pump fluid into it, and the capsule pumps fluid out. So you can't suck calcium. Like it'd be sucking toothpaste for an 18 gauge needle. It doesn't suck. It does suck, but it doesn't suck. But you basically just barbotage, or you gently with a 3 cc syringe, and you don't want to poke multiple holes in the calcium deposit, because if you want it to be able to pressurize, and so you poke one hole in the calcium deposit. Once you see it in there, you just basically a third of a cc pump. You'll see the capsule expand, and it blows out calcium. And you just keep pumping, and it blows out more and more calcium into the syringe. And then you change your syringe because it's gravity, so the calcium sits at the bottom, because otherwise you're just pumping the calcium back in. Change your syringe out, do the same thing, pump it, and eventually just blows it all out. And you're left with this base collapsed space. So that's kind of cool. And doesn't work on resorptive or formative phase, because that's kind of diffuse in the tendon at that point. Tenotomy is another form of treatment. We usually use a device to debride the tendon itself. In this case, this will be a 10X device. There is like a 10-jet device, which uses fluid instead of ultrasonic waves. The wave, they both work okay for calcific tendonitis. So this is kind of a video of, this is the patient actually, this is the calcific tendonitis. This is just it's called a no-core needle. I use it as a knife to make a track into the tendon. And then you see the cutting edge. And then I work on the tenotomy device, put the tenax in, you can see the tip here, and when it turns on, you'll see it, there it goes. You'll see artifact below, and this thing just, it doesn't actually, it's not like a jackhammer, it vibrates 22,000 times a second, so it's like removing cataracts. So you put it next to the non-movable tissue, and it just fragments it. It has about a 1 millimeter zone of which it's just fallen apart. But living tissue will vibrate with it. So unless you leave it for a long period of time in living tissue, it doesn't do anything. But non-pliable tissue, it just shakes apart. This is once again a tenotomy. This is so we're in the shoulder. We're expressing calcium. In this case, this was interesting. This is the calcium that came out of the shoulder. There's the image up on the screen. And I just want to show you, so occasionally these devices will get clogged with calcium, and so you just pull them out and just blow the calcium out of the device and then put it back in. And so it takes a few minutes. As far as time, it's about 15 minutes to remove like a big calcium deposit like that. Otherwise, anything between 4 and 15 minutes, so they don't take long. So this is another possibility. As far as, so my problem with what we've talked about is you leave a hole. So you just leave a big, like a hole in the rotator cuff when you're all finished with this. And it wasn't a tear like you separated fibers. It's more like a longitudinal split tear or delamination that occurs, splitting the fibers on their long axis. So the question is, what do you do with it? So this is just a small study that they talked about. Well, what do we do with these things? And in the end, if you add PRP to these after expression of the calcium, because calcium is non-living, it doesn't have feelings. It's just a space-occupying lesion. So if I inject PRP into a non-living thing, nothing will happen. Like the platelets aren't going to magically absorb the calcium deposit. However, if we do create inflammation around it, so the calcium is exposed to the body, then there is some absorption that can occur, or a lot of absorption. So this is what this is saying. So even though I do a good job at removing the calcium, I'm not going to get it all in most cases. And so we use PRP a couple weeks later to basically just keep it in an inflammatory phase, which will resolve the rest of the calcium. And this just shows that, like, as far as like possibilities that exist, steroid versus a PRP, the PRP does better. The funny thing about this article, it went out to 2 years. So following, I don't know where it says it, but anyway, it went out to 2-year follow-up. Are you going to be super happy with your calcific tendonitis, like during the first year if nothing happens, but at the second year? So what I was saying is, you didn't know whether this is a resorptive phase, just a calcific phase, what was happening on in this. 2 years is a long time to get better. Like, oh, it'll only take you 2 years. Go ahead, like that's a long time. But yeah, PRP did great with that one. This is just a PRP injection into residual calcific tendonitis. Did you see the capsule kind of blow up? So this is one that had collapsed, and we put the PRP in it. It blew it up, and then we fenestrate that area to cause inflammation. This is that ribbon-like streak of calcium I talked about earlier. These are ones not well seen or visualized on MRI or it's called tendinosis on MRI or X-ray. It's because it's laying flat in the longitudinal direction of the fiber. So those are a little bit more difficult to see. And those are some references. Thank you. Oh, sorry, before I end. The other, people have shockwave therapy. Does anybody do shockwave therapy in here? So shockwave therapy is another modality that you could use for calcific tendonitis, where it's in that, like possibly in the resorptive phase or even the formation phase, but when it's in that encapsulated state, it's a little bit more difficult to tell a patient, hey, spend $1,200 on this, we'll fix it. Because I don't know if you bill for it or not, but shockwave therapy is not covered by insurance. And so it's not an accepted form of treatment. However, it does show promise in the treatment of calcific tendonitis. So that would be another modality. Sorry, one more modality because you guys do it a lot. Dry needling. is very good for roughing up an area, exposing it to the body. So that could be also very, very effective for calcific tendonitis. But that's it for me.